Hello and welcome to the Making Medicaid Data More Accessible Through Common Data Models and FHIR APIs webinar series. Before we begin, I'd like to provide a brief overview of this project, which addresses the federal priority to expand data capacity or data infrastructure for conducting patient-centered outcomes research, which is often abbreviated as PCOR. That informs decisions about the effectiveness of health interventions used in the Medicaid and children's health insurance programs. The Transformed Medicaid Statistical Information System, known as T-MSIS, has analytical files that are suitable for research. These are known as TAF RIFs, as part of a new research-optimized national Medicaid dataset that begins in 2014 with full representation from all jurisdictions in 2016. These files include data on Medicaid and children's health insurance program enrollment, demographics, service utilization, and payments. This project created open source code to format these data into the FDA Sentinel and Observational Medical Outcomes Partnership common data models to improve data access, accelerate analyses, and enable multi-data-based studies. The aim of this webinar series is to educate researchers who are using or plan to use Medicaid data about the new data transformation tools and to disseminate major findings. Each video in this webinar series is a chapter that covers a key project objective. My name is Keith Marsolo from Duke University, and I'll be leading the fifth chapter in this series, which discusses the feasibility of using fast healthcare interoperability resource specification to enable EHR data linkage with administrative claims, with T-MSIS data as a motivating example. As I said, I'm Keith Marsolo. I'm a professor in population health sciences in the Duke University School of Medicine and a member of the Duke Clinical Research Institute. Please note that the views expressed in this presentation are those of the authors. They do not necessarily represent the official position of the U.S. Department of Health and Human Services or the Food and Drug Administration. The work in this presentation was funded by the Office of the Secretary Patient-Centered Outcomes Research Trust Fund, which is made available to FDA by the Office of the Assistant Secretary for Planning and Evaluation through an interagency agreement. The U.S. FDA funded the Sentinel Initiative contract. In this presentation, I'll provide an overview of the aims of this project and then highlight some background information on T-MSIS and FHIR, as well as advances in the sharing of healthcare data that have been spurred by the 21st Century Cures Act. I will then get into some of the technical requirements that would be needed to support data linkage with FHIR, with a motivating use case to sort of frame our example, and then some of the downstream ramifications on patient matching and data governance. I'll highlight some additional factors that need to be considered in any linkage project, including how to handle encounter-level linkages, what to do about quality control, the sort of impact of latency, and then cost. And then finally, I'll close with a summary and conclusions. So the overall aims of our project was to develop a white paper assessing the feasibility of using FHIR to enable the linkage of EHR data with administrative claims. The reason, sort of the motivation behind this, is that linking claims and EHR data expands the type and the scope of research questions that can be answered. This supplements the complete capture of medically attended events that are found in claims with more granular information that can be available within EHRs, such as vital signs, laboratory results, in inpatient medication administrations. Given that the overall project focus has been on Medicaid, in this white paper, we use a theoretical linkage between the T-MSIS TAF RIF files and then EHR data as our example use case. So T-MSIS is operated by the Centers for Medicare and Medicaid Services, or CMS, and as I said, it's a compilation of data from Medicaid and the Children's Health Insurance Program from states and territories across the United States, as well as the District of Columbia. There's a version of the T-MSIS data that are geared towards research. That's the TAF RIF files. And as I said, these can include data on beneficiary demographics, eligibility, program enrollment, providers, payments, service use, and more. The other item that I would note here is that research who want to use the TAF RIF data must request it from CMS and enter into a data use agreement that includes sort of certain restrictions and responsibilities for the researcher. And for more information, you can follow the link at the bottom of this slide and see some other videos in this webinar series on more use of the TAF files. So FHIR, the Fast Healthcare Interoperability Resources Standard, was designed to support the exchange of health information that is published and maintained by HL7 or the Health Level 7 International Group. It's a standard that defines both the structure of the data to be exchanged, for example, the format of a record, whether fields are required or optional, as well as the content of the data in terms of the value sets and associated terminologies that can be used. And while there's some flexibility in the specification, it's really intended to help ensure the compatibility and interoperability of information across sources. And one of the major innovations of the FHIR specification is how data are transferred between systems. FHIR leverages application programming interfaces, or APIs, which are used by many modern web applications to exchange small, discrete pieces of data or information. FHIR was designed to support a variety of use cases. These include clinical care, such as the basic treatment of patients, as well as more advanced methods of decision support, research and public health, health plan administration, or the exchange of information between health systems and health insurance companies, and then finally to support the direct access of data by patients. And FHIR has also been specified as the standard for health data exchange in federal legislation within the United States, including the 21st Century Cures Act. So 21st Century Cures was passed by the United States Congress in 2016. The bill included a number of provisions related to the sharing of data, with specific mandates for both the Office of the National Coordinator for Health Information Technology, or ONC, as well as with CMS. Examples include that CMS-regulated payers must support FHIR APIs to share data with their patients, or for patients to be able to request the sharing of their data between payers and providers to help improve the secure access, exchange, and use of health information. Another mandate for the ONC is that certified health information technology, such as electronic health records, must support the exchange of data elements and associated terminologies that are part of the United States Core Data for Interoperability, or USCDI, via the FHIR standard. The upshot of these mandates is that health systems and CMS-regulated payers have been gradually implementing FHIR capabilities within their health IT systems, making it an ideal time to assess the feasibility of using FHIR to support the linkage of EHR data with administrative claims. So our example use case for this work is one where a requester, who can either be an individual researcher or an organization, has or is planning to obtain EHR data with personal identifiers for a cohort of patients. They would then wish to link these EHR data with administrative claims from T-MSIS. As I mentioned earlier, there are some regulations around access to T-MSIS data, the TAF-RIF files. So we are assuming that these are already in place and that the requester has the appropriate approvals. Now, the traditional approach to linkage of data with CMS is that the requester would send a Finder file to CMS with patient identifiers, and then they would receive a claims extract back that they could use to link with their EHR data. In this revised workflow, the requester would use FHIR APIs to identify patients and exchange data. Our discussion today is focused only on the steps for initial patient matching, not any of the subsequent exchange of patient records. And in this scenario, CMS is the claims data holder, but the approach that we're describing could be applied to other health plans that have the same underlying technical infrastructure. So one of the first questions is whether we can expect the TAF-RIF files from T-MSIS and the EHR data sources to include the necessary identifiers that would be needed to match or to link patients across the sources. Now, the specific process of determining whether a patient is a match, whether it relies on deterministic or probabilistic methods, is really sort of dependent on the data holder. For the purposes of this white paper, we're agnostic. At the end of the day, they're still going to rely on the same underlying patient identifiers, so it's important to assess their availability. The table on the slide here shows the identifiers that are often used to link patients, to match patients, as well as their availability within T-MSIS and the U.S. Core Patient Profile, which is the FHIR implementation of the US CDI and a representation of what might be available within the EHR. As we can see, almost all of the fields are present in both sources, and while more of them are considered to be optional within FHIR, within the EHR, it is more likely than not that they would be recorded and be available for use. So from a purely technical standpoint, both sources include the relevant identifiers that would be needed to support linkage. There are still some governance challenges that may need to be addressed, however. The adoption of FHIR has made the exchange of health data more straightforward by defining a common standard that everyone in the industry can implement. The current use of FHIR at a health system level, however, is primarily to support clinical care for operational purposes like prior authorization or to allow patients to access their own health records. The transmission of patient identifiers to external organizations via FHIR APIs for the purposes of research or public health surveillance is still relatively novel across the industry and may require changes to health IT policies at an organization or additional language in project contracts or data use agreements to fully allow the identifiers to flow. Beyond the governance issues highlighted previously, there are some other items that need to be considered as well. And again, these are issues that come into play with any sort of linkage activity. One is related to linkage at the encounter level. So when it comes to merging EHR and claims records, each source may have data for the same quote-unquote encounter or service. So care must be taken if there's a desire to streamline or deduplicate that information. In the beginning, it may be easier to maintain records of provenance of the source, to, for instance, say that the record came from the EHR or from a claim, and have analyses rely on dates of service instead of using any kind of encounter identifier itself. Our example use case was focused on T-MSIS. In terms of quality control, T-MSIS maintains a list of data quality measures that are run against submitted data, and these results and other information are presented in the CMS Data Quality Atlas. This information is readily available to researchers who want to use the data. If this theoretical workflow that we described were used with other claims data holders, it would be important to understand the quality measures that exist for those data and whether they can be shared with external investigators. Latency can also be a big factor when dealing with EHR data claims. Administrative claims are often not available to investigators for several months or even years after an encounter, which may impact their utility for any kind of real-time linkages or prospective analyses. Finally, the cost for a payer or health plan to set up and maintain a patient matching and linkage workflow for research using FHIR may be non-trivial, especially if these data holders have other workflows in place to support this activity, such as finder files. In summary, we've described the theoretical linkage for research between EHR data and the TAF-RIF files using FHIR. FHIR APIs can provide an alternative strategy for patient linkage over the traditional finder file approach, one that could potentially apply to linkages with other claims data holders. There may currently be governance challenges and cost barriers to establish all of the necessary infrastructure. However, given the widespread adoption of FHIR APIs by health systems and health plans, an API-based approach to linkage may become more tractable in the future. Thank you for your interest in the feasibility of using the Fast Healthcare Interoperability Resource, or FHIR specification, to enable EHR data linkage with administrative claims with T-MSIS data as a motivating example. If you'd like to learn more about the Making Medicaid Data More Accessible Through Common Data Models and FHIR APIs project, follow the links shown in the description field below. Links to other presentations will be included, and all webinar chapters will be made into a YouTube playlist. Thank you for your time.